Good morning. We are now on the record. Here begins video 1 in the deposition of Mark N. Awantang, MD, testifying in the matter of Michael James Nelson versus John Walker Dara III in the Circuit Court of the 14th Judicial Circuit in and for Bay County, Florida. Today's date is May 1st, 2019, and the time on the video monitor is 1:04 a.m. Your videographer today is Eric Kraft, representing Baytown Reporting. Will counsel and all present please identify yourselves and state whom you represent?
Larry Perry, and I represent Michael Nelson.
Laura LaBianca Puente, and I represent John Walker Dara.
Your court reporter today is Catherine Southall, and she can now swear in the deponent.
Doctor, if you'll raise your right hand for me, please. Do you solemnly swear or affirm the testimony you're about to give shall be the truth, the whole truth, and nothing but the truth to help you God?
I do.
Dr. Awantang, my name's Larry Perry. We got introduced for the first time ever just a few moments ago. I'm going to be asking you questions this morning regarding the care and treatment that you provided for Mike Nelson. If you don't understand a question, please let me know. And the purpose of this is to show your video deposition to the jury to explain the medical care and treatment that you provided to him. First of all, let's get to know you a little bit better. Dr. Awantang, what type of doctor are you, and are you licensed in the state of Florida?
Yes, I'm orthopedic surgeon, especially in upper extremity.
Okay. And how long have you been licensed in the state of Florida?
Since 2012.
Okay. What did you do to receive a specialty in the upper extremity? And we're talking about arms and hands.
I spent a year at UAB doing a fellowship.
University of Alabama at Birmingham.
Mm-hmm.
And what does it mean to be fellowship trained in upper extremity surgery?
Get extra training in upper extremity surgery, and generally also means you kind of specialize and do more of that.
Okay. Did you work any of the trauma unit or work any of the trauma surgeries in Birmingham, Alabama before coming here?
Yes.
And you did that during your year of fellowship?
Yes.
All right. You had the opportunity to see Mr. Nelson. How did he become a patient of yours?
I don't remember if I was on call or not, but he came in through Gulf Coast.
Okay.
Medical center with an open fracture, and I took care of him there.
Okay. So had you ever seen Mr. Nelson before?
No.
But looking at the records, it's your best recollection that you saw him because you were on call?
Yes.
Or the group was on call and because you have the specialty in upper extremities with the open fracture of the left hand and wrist, you were called in?
Yes.
All right. Tell me what you did and when you first saw Mr. Nelson and what the decisions were made that evening.
So he was seen at the hospital. He had a badly deformed wrist. X-ray showed he had a comminuted fracture of the distal radius, which means a lot of pieces, unstable. He also had smaller fractures of the ulna. He had a small wound over the ulnar aspect of his wrist, and this makes it more emergent because anytime there's a wound, the chance of infection rises. So because of that, otherwise he may have been discharged, but because of that, he was taken to the surgery quickly.
Okay.
And we opened up the wrist.
But before we get into everything that you did, you mentioned a lot of medical terms in describing where the injury was. We've got some photographs, we've got some medical boards, we've got x-rays or photographs or copies of x-rays, and we've got a hand model. Can you please describe for the ladies and gentlemen of the jury or using these items what you saw and what you found on x-ray and what you did?
Okay, well, it will probably, this is probably the, should we move that out of the way real quick? Probably be best to, this is probably the best way to explain. So I presume these are his pictures.
Those are his pictures.
Yeah, but so here you have obvious deformity. This is the ulnar side. The wound was actually on this side. It wasn't really big, but you can see there's a little bit of blood coming out. You can see the whole radius is crushed, shortened, which is why he has this deformity. This was the wound, like I said, which wasn't big, but anytime you have one, it does increase the chance of infection.
And you said it was a comminuted
So-
fracture. What does that mean?
Comminuted just means it's a lot of pieces. And so you can see in this picture, it's a pretty good representation that there's a lot of different pieces of bone, and this makes it more difficult to treat and definitely more unreliably treated without surgery.
Okay. And when you say more difficult to treat without surgery, what do you mean? Did he have an option of surgery or no surgery?
Definitely surgery was recommended in his case.
Okay. And you mentioned the radius and the ulnar. Can you point out on the diagram
So-
where the radius and the ulnar are?
So the bigger bone in your wrist is the radius, and most of the weight in your wrist goes across that. But in addition, you have a smaller bone called the ulna, which the radius actually rolls around or rotates around, and both were broke. And in his particular case, the significance of the ulnar fracture isn't so much stability in terms of the deformity or the way his wrist looks, but if you have when you have a ulnar fracture the way he had it sometimes can affect your rotation, which is why we also operated on the ulna, which we don't always do.
Okay. All right. So does that fairly and accurately depict how you saw Michael Nelson?
Yes.
Okay. Let's put that aside, and we've got another board here that might be able to assist with the surgery or the surgical techniques that were used. But if you can, let's first describe with words the surgical techniques that you did with Mr. Nelson, and then perhaps if the boards are helpful or the model's helpful, to explain to the jury what you did.
Well, pictures are good.
Okay.
So, in an instance like this, one thing you want to do is you want to wash out the wound, and none of the pictures really show it. This is approximately where the wound was, and so we irrigate that out, wash it out as well as we can. He gets antibiotics to try to minimize the chance of infection, and then we expose the radius, which in his case means we make a decision on the volar side of the wrist, which is the upside or the side
So
your
if
palm
somebody
is
turns
on.
their palm up, that's the side that you did the surgery from.
We dissect down to the bone, basically, and then try to put the pieces back together. In his case, we used a plate that's a little longer than typical because most distal radiuses aren't so high energy and don't have this amount of comminution, but we used one that was long enough so that it would bridge the area. You actually pull on the hand to try to get it back out to length. As you saw from that previous picture, his was shortened and deformed, so you manipulate it to try to get it back into the right position. In cases like his, where you have this much comminution, there's actually defects in the bone where, because there's been so much energy into causing the injury, even when you pull it back up, there are basically areas that are crushed. And so we put some bone graft in those pieces to try. Number one, it gives you a little structural support. Number two, it speeds up healing a little bit.
Okay.
So once we got the radius back into acceptable position, we then check rotation, and per my notes, he had some instability, and so that was the reason for the extra K-wires, where we put in.
And sometimes people call the K-wires pins.
Yes,
Okay.
that's the reason we put in the K-wires or the pins, and to put that piece of bone back. Some of the ligaments that go across this joint here attach onto that bone, and so if you put it back and pin it, you get more stability. But it's also the reason for this K-wire cross to keep that joint stable.
Okay. And so plates, screws, pins, and when you say the word comminution, in layman's terms, is that breakage?
Lots of pieces.
Lots of pieces. Okay. And utilizing the model, can you kind of demonstrate where you went across or how you went across, or is it better just shown there in the photograph?
It's a little difficult on this because this really doesn't go down as far, but it would be basically between this we dissect between this tendon, which is the flexor carpi radialis tendon, and the radial artery. So we make an interval there, open it up. There's a muscle called the pronator quadratus. Now, in his case, that would have been pretty torn up anyway because the bone was so damaged, but we lift that up off the bone, and that's about it.
Okay. And so it's not in the hand itself, but the upper portion of what we would call the wrist.
It's a distal forearm is what we'd call it. But
Okay. All right. So the surgery itself, would you consider it to be a success?
Well, so in as far as getting the pieces back together and getting it to heal and getting stability of the distal radial ulnar joint, yes. So there's a lot of measures of success.
Right.
So, in terms of motion and function, you can't always predict that when you walk out of the operating room.
Okay. One thing that you haven't mentioned are the nerves that kind of come through this area. What are the nerves that come through this particular area?
Well, so the main nerves be the ulnar nerve, the median nerve. You have, those are the bigger ones, the ones responsible for motor function. You have smaller nerves that involve in sensation, but I don't,
Okay, that's fine. Did you have to resect or dissect or attach any nerves?
I didn't resect or dissect any nerves specifically. I didn't dissect or.
Okay, but the nerves are going through this area.
They are.
And so when somebody says that this is an unnerved area or some area that has nerves that run through it, it has two major nerves that run through it that affect the motion, use, and function of the hand.
Yeah, it's a general statement, but yeah.
Okay, well, how would you say it? How would you say it? Say it better for me. Then. How about that?
So I mean, so for most distal radius fractures, the nerves aren't a big issue, but they can be. And when we say how the nerves are affected, so you have the two big nerves that if are they actually damaged or contused, that has one kind of set of clinical sequelae, versus you also have more generalized things. You have something called complex regional pain syndrome, which is honestly not really well understood, but also involves the nerves, but not necessarily, it doesn't necessarily involve direct contusion or injury to one nerve. We really don't always understand how it happens, but it does happen with injury sometimes.
Okay. And so this surgery that was performed on Mr. Nelson, it needed to be in a hospital or in a surgery center?
Yeah. So in an operating room.
In an operating room
Yeah.
somewhere. And he needed to be under anesthesia to have this done.
Yes.
And you felt like it was reasonable, medically necessary to have the surgery performed on him.
Definitely.
What were the next steps following the surgery? What did you do?
So after he was I don't have the hospital records, but I'm willing to bet that he probably stayed at least a night in the hospital and got antibiotics, because that's what we do for this type of injury. He then would follow up with us roughly about 2 weeks later.
Okay.
We take off his splint and then we put him in a cast. Okay, and then and we keep checking on him and we start emphasizing his motion, because all distal radius fractures are at risk for hand stiffness, and particularly in a bad injury like this, all the more so with him.
Would you give him some at-home exercises, prescribe physical therapy? What would you do?
Well, we kind of do it on a case-by-case basis, or at least I do.
Yes, sir.
So if it's a person and they're able to move pretty well, like on the early post-op visits, then maybe we just do the home exercises. But if they're struggling, they're having difficulty, then we try to send them to therapy because it looks like they need more help.
If somebody, do you recall what you did with Mr. Nelson, or do you have those notes?
I have to check.
All right. I think some at-home exercises were provided to him, but I may
So it's like 3:30 instructions to move his fingers as much as he can. So I know we sent, told him to go home and move it. And let me see. See that last visit. So we did send him for physical therapy. This note from July, we sent him for physical therapy.
Okay. So about 4 months post-accident.
Yeah.
Recommendation. By that point in time, would his cast have been removed?
Yes. His cast was removed.
All right. All right. So you had follow-up visits with him at the clinic. How many follow-up visits did you have? And as I look at the notes, sometimes Mr. Nelson is seen by the physician's assistant.
Yeah.
But you would review the case with the physician's assistant?
Yeah. So 1, 2, 3. 4. It's like 5. It looks like he had 5
Okay.
visits.
And during some of those visits, you would see him also?
Yes.
There appears to be, along the way, following the operation, that you would do a series of x-rays
Yes.
for a period of time. And what's the medical purpose for those x-rays?
Make sure it's healing. Make sure nothing's changed. Like you haven't lost the reduction. Those are really the 2 main things. To make sure you didn't. What you put back into place is still in place, and that it's healing.
Okay. And you're looking at that from an orthopedic standpoint. Basically, are the bones aligned? Is everything aligned in the right position and right place?
Yes.
And from an orthopedic standpoint, did Mr. Nelson appear to have a good recovery during that post-acute phase or post-accident phase?
Yes.
He didn't sustain any type of bone loss and didn't appear to have anything that was done to the arm that took it out of alignment or moved any of the surgical items that you had put in place?
No.
Okay. Was Mr. Nelson compliant with everything that you asked him to do?
As far as I can recollect, it's
Okay.
a long time ago, but yeah.
If there had been something that he had not been compliant with, would you have made a note of it during the course, or your physician's assistant? Would your physician's assistant been instructed to make a note of it? So, for instance, if he were lifting something he shouldn't be doing or performing some type of work he shouldn't be doing, those are, or other examples.
Probably, yeah.
Okay.
Probably.
And when was the last time, if you can, just give me the dates that you followed up with
So
Mr. Nelson, and then what was the last time that you saw him?
looks like we saw him on. This is all in 2016. We saw him March 30th, April 18th, May 2nd, May 4th, and July 11th.
Okay.
Those are the records I have.
I noticed in some of the records that there's something called a grade 1 open distal radius fracture. What does that mean?
So grade 1 just means that when I was describing earlier that he had a wound associated with the fracture, that it was small, which in grade 1 means is 1 centimeter or less.
Okay.
That's what that means.
Everything that you did for Mr. Nelson, was it within a reasonable degree, or was it medically necessary first?
Yeah.
And as far as the cause of the collision, you had to, or the cause of the reason he came in, you had to take that from a history from somebody else. You didn't witness the collision.
Did not witness the collision.
But the injuries are consistent with, as I think you put it, a high energy
Yes.
commutation or
Yeah,
breaking up of the bones.
For this, you wouldn't see this in someone his age because they just fell down from a standing position. Is more energy than that.
Okay. And I take it that you charge for your services?
I hope so.
Yeah. That's something we'll take up with the department, the building department, but you charge for your deposition
Yes.
time here today as well?
Yes.
Your clinic does?
Yes.
All right. The last time that you saw him was in 2016?
Yes.
And if you had any follow-up visits with him, do you know if he changed care with different physicians or what happened there?
Well, coming in here today, from the records, I assume he did, but prior to today, didn't know what had happened to him.
Okay. All right. That's all the questions I have for you. Opposing counsel will have a few questions and we'll be done.
I have a couple follow-up. I have here some records of similar to the ones you have in front of you. So if you need to reference them at any point in time, just ask me. I'm not sure if we've got the same set, but Mr. Nelson, when he came to see you at your office after you performed the surgery, did he inform you or your staff that he smokes?
I believe so, because I see we counseled him to stop smoking, so yes.
You counseled him to stop smoking.
Yes.
He was smoking 1.5 packs a day.
I don't remember how much he smoked. but-
And if I give you some records, I might refresh.
Yeah, well, that's what he wrote down, so I believe it.
All right, so 1.5 packs a day. You counseled him to stop. Did you counsel him to stop because it affects healing?
I did, yeah. Yes, I did.
Could it cause a malunion?
Potentially, yeah.
Did Mr. Nelson continue to smoke throughout your treatment with him? Better yet, did you ever make any note that he stopped smoking?
I did not.
If he had informed you he had stopped smoking, would you have made such a note?
Yes,
Would it be your assumption that he continued smoking?
yes.
Did you continue to counsel him to stop smoking? Better yet, if it was your belief that he was continuing to smoke, would you have continued to counsel him to stop smoking?
We would try, but
Okay, we would try. That's fair. When Mr. Nelson saw you in the first 2 to 3 weeks of his surgery, there were no obvious signs of infection, correct?
correct.
And throughout your treatment with him, at no point in time were there any signs of infection, correct?
Correct.
And on March 30th, 2016, during that visit, he was prescribed Bactrim.
Mm-hmm.
And is that an antibiotic?
It is.
And is that a prophylactic measure?
Yeah, and to the best of my recollection, I think it's because he had this open wound here as well, which we usually don't close because, for one thing, it's so massive, beat up that you can't just easily close it back together. But that would be the reason he would get that.
Okay, so you give him the Bactrim to make sure he doesn't develop an infection.
Mhm.
Okay. You never saw any signs of erythema, right?
Not to my recollection. No.
Nor any signs of redness? Refer you to the May 2nd notes.
Let me. Correct.
Okay. And on July 11th, 2016, was that the last time you'd seen him?
Yes.
And at that point in time, he was in a brace, correct?
Correct.
And he was allowed to, while wearing that brace, push, pull, and lift things?
Yes.
And thereafter, were you provided any report from physical therapy regarding Mr. Nelson's progress?
I have to check the records because I really don't remember if I was or not.
And do you know your fax number? Is it 785-9681?
So this does look like it was. So we did. What are the dates here? Yeah, so we did get some.
Okay. And did you review those at any point in time?
I may have done, but it's 3 years ago, so
Okay.
I haven't reviewed them.
I'm
recently.
gonna ask you, I think, one question about it. It notes in there that patient has or currently has the following: osteoporosis, and since you referred Mr. Nelson to them, do you have any information regarding an osteoporosis diagnosis?
No, and I probably don't agree with that.
Okay.
But,
Okay. So you don't think Mr. Nelson has osteoporosis?
No, technically the only way to tell that for sure is to get bone mineral DEXA scan, and there's no indication for a 30-year-old male to have osteoporosis.
Okay. And so you didn't do a DEXA scan?
No.
Okay. And so you haven't seen Mr. Nelson since July of 2016?
Correct.
You don't know of his present
I
condition?
don't.
So you would not be able to give us an opinion here today regarding any future care, correct?
That'd be difficult.
And you mentioned earlier that those boards that you were referencing, that they looked pretty good. Just so I can be clear, they're pretty good, but they're not an exact representation of the inside of Mr. Nelson's wrist
They're not.
as you saw him on the date of
They're
your
not.
surgery, correct?
Correct.
I have no follow-up questions, thank you.
Okay. Just real simple, we're going to mark the exhibits, meaning your copy of your notes. I have a copy of your billing that I will attach also as an exhibit.
All right.
And the photographs of the x-rays that you took post-operatively here in the clinic.
Okay.
And with that, you have the opportunity, if you wish, to read the deposition after it's typed up, or you can waive the reading of the deposition and just rely on Ms. Edwards that she typed it up correctly.
We'll probably rely on Ms. Edwards.
Okay. Thank you for your time, sir.
All right.
Thank you.
All right.
That concludes today's deposition. The time is 9:31 p.m. a.m.